so we can have this conversation, this much needed conversation.
Absolutely.
And you know, I should have included in the questions.
YouTube on Dr. Delvena Thomas, so we can have this conversation.
The rates
this
of,
much needed conversation.
I'll probably have to use my phone to see the questions that come through. But
and you
the
know,
rates of,
I should have
prostate cancer in Blacks versus whites, if there's a disparity or a difference in.
Yeah, there's a disparity in diagnosis. It's not much, but there is one.
For some reason, you're frozen now. Yeah, your screen froze. Oh, okay. All right, there we go. So maybe it's just the way it's streaming. All right.
So I can't see you. I can only see a black box. I don't know if
I can hear I'm good on my end. I wonder if it's your Wi-Fi. What do you think? You have pretty good signal strength there?
Yeah. Let me move and see if it.
Yeah, that might be better because I think that's probably because I'm good on my end.
You can see me?
Yes, I can see you now, but it was frozen. So to everyone who's joining us, we're getting situated so that we can have this discussion about prostate cancer. Dr. Morris, my special guest tonight. I see some of you are watching already, and I appreciate that. I put out an event link this time so that way people would get the notification. And I will try to check for questions on YouTube. So if you have any questions,
Dr. Morris, my special
let's see.
Tonight, I see some of you are watching already, and I appreciate that.
Let me turn down the volume.
I still can't see you, but I can hear you, so it's all good.
Yeah, but you're frozen. So let's do, yeah, now it's almost like, I think you need to go closer to your router. Maybe go out and come back in. It could be that because like I keep seeing like frames of movement.
Yeah, I'm moving.
Yeah, but then you're frozen. Like I'll see you'll move and then it stops. But I hear you talking. So I think it's the Wi-Fi on your end because I'm good over here. We're streaming on YouTube, it's there. So while you're getting situated, and maybe if you want to go out and come back in.
You want me to exit the actual, okay.
Yeah, exit the Zoom and come back. And what I'll do is I'll just go over your bio now.
Okay.
So that way we do that. And people, to folks watching, it's Therapy Thursday. I'm Dr. Delvena, psychiatrist in South Florida, DRT Behavioral Services, Brain Love. And I'm talking about prostate cancer tonight. And the reason being is because it's an area or a section of medicine that people really are not knowledgeable in. And it's the most common cancer in men. So this is something that we should absolutely discuss. I have a really good guest tonight. He and I actually trained at the same hospital in Baltimore, the University of Maryland in Baltimore off of Green Street. In downtown, he was in the Hem-Onc program, which is hematology and oncology, and I was in the psychiatry residency. He was actually in internal medicine, pardon me. So Dr. Jeffrey Moore. So people don't really understand the training that some specialists have to go through to be qualified to treat you for your condition. So when folks have cancer, they see an oncologist. That specialist is also trained in something called hematology. So we call it Hem-Onc in medicine. But before they can even study Hem-Onc, they have to undergo a residency in internal medicine. So let's talk about really briefly just the major specialties in medicine. So there's family practice. You guys know those are doctors who can treat people from the time they're born all the way until they die, basically. So they treat every age. A lot of them would treat women, men. They'll do gyne exams. They'll do a lot of different things. They combine gynecology, dermatology, everything that you need a family practice doc can do for you. But when things become a little more complicated, they'll refer you to a specialist. Internal medicine doctors, so family practice doctors, they undergo a residency that's 3 years. Internal medicine doctors, their residency is 3 years as well. So once they finish their residency of 3 years, they are internists, that's what we call them. So internal medicine doctors and family practice doctors, they are primary care physicians. But internists, a lot of them, well, some of them, I should say, will subspecialize. They'll go into other specialties that require an additional 3 years of training, which is paid training, but not as much as they would make if they were a specialist. So they're still training. So there's 4 years of medical school, 3 years of an internal medicine or IMed residency, and another 3 years in their specialty. So a heart doctor who's a cardiologist, they'll do 3 years after medical school in internal medicine, and then they'll train for 3 years in cardiology. A GI doctor, gastroenterologist, they'll do the same. 3 years of internal medicine, 3 years of gastroenterology training or GI training to become a specialist. Rheumatologists, people who treat rheumatoid arthritis, lupus, autoimmune diseases, same thing. 3 years of internal medicine, 3 years of a rheumatology residency. Dr. Jeffrey Moore, who we trained at the same hospital, he was in internal medicine, I was in psychiatry. He is the only Black oncologist I know. And so he is not here in Florida, he is up in Virginia. And I asked him to please come on because I know a lot of Black men who look like Dr. Moore, who don't understand the process of prostate cancer or what it is, and also their wives and sisters and daughters. We don't understand these things sometimes. So we got to break it down, because when you get in the office with your doctor nowadays with healthcare, you got like 5-10 minutes to like spit up all these questions. And when we're talking about cancer, that's not enough time, man, for you to understand what's going on. And so, yes, Google is available and you can learn so much on Google, but let's not do that. Let's share information and make it easy to learn. So Dr. Jeffrey Moore received his medical degree from the Temple University School of Medicine. Told you he did his residency at the University of Maryland Medical Center in internal medicine. When he finished those 3 years, he moved up to New York to complete his hematology and oncology fellowship at Columbia University Medical Center. Very well-trained brother. Dr. Moore's research experience includes exploring novel chemotherapy regimens for the treatment of advanced pancreatic cancer, which used to be a death sentence. And now it seems like people are actually surviving. We won't get into pancreatic cancer, but I remember when I was in college, there was a researcher who developed pancreatic cancer and he died within 6 months. But I'm noticing that people are living longer who have been diagnosed with pancreatic cancer. And just like with any type of cancer, it has to be staged. So Dr. Moore, unmute yourself, please, just in case I say something that is absolutely wrong, because I know this is not my lane. Welcome to Therapy Thursday.
Thank you for having me, Dr. Delvena. You're spot on with your, first of all, thank you for having me and that fantastic intro. It's problematic that I'm the only brother that you know that's a medical oncologist, but I guess we'll talk about that at some other time.
Yeah.
No, but you're spot on in terms of the training that we all go through, in terms of being an internist and then going on for subspecialty training like I did in medical oncology and hematology. So, one thing I've always respected about you that, maybe your audience may not know is that you've, although you're an expert psychiatrist, you're just a fantastic all-around doctor with good knowledge and good skills in all of medicine. So that's really the big.
Oh, thank you.
You've always been on point with that. So.
Thank you, Dr. Moore. I appreciate it. And folks, if you're watching and your kids aren't watching, this is something you got to show your kids later so that they see this. 2 Black minority physicians talking about medicine so that we can inspire some more Black folks, minorities, brown people, people of color, Negroes, African Americans, aka whatever you want to call it. We need more. And like you said, it's a problem that you're the only one I know who's an oncologist.
Right.
All right.
Absolutely. I agree 100%.
So
we need more people like us treating people like us.
There it is. I have to quote that. So I told you this will be a podcast too. Said by Dr. Moore, Dr. Jeffrey. You're from Pittsburgh, right?
Yep, born and raised in Pittsburgh. So grew up there through high school. Then, you kind of gave the rest of my bio. Went to Philly, Penn undergrad, Temple, Maryland, where I trained with you, New York for a few years. And I've been here in private practice in Northern Virginia, in the DC suburbs. So Alexandria, Virginia, Fairfax County, Prince William County. I've been here for the past 11 years. So.
Okay. Perfect. So guys, he is no slouch. He ain't a slug. This is a very informed physician. So I'm bringing you the best of the best. I always tell people you got to look at the reference, right? You got to look who's talking. Why should you listen to them? I have proven that Dr. Moore is qualified to speak on this topic. So let's dive in. All right.
Let's do it.
First question. And folks who are watching, listen, call 951 my brain, 951 my brain. If you have a question, 951 my brain, BRAIN. And you can ask your question. He can hear you here. But the first question I have, what is a prostate?
So the prostate is an organ that's found in the pelvis of men, and it's a part of our genitourinary system. Essentially, a part of the system that we use to urinate, expel urine, and also involved with sexual function. It's just below the bladder, sort of sits at the base of the bladder and around the urethra, which obviously is how we expel urine. And it's usually about the size of a quarter or a walnut or so in most men, most young to middle-aged men. The function of the prostate is to produce and excrete prostatic fluid, which is a part of semen. And essentially what it does is it helps sperm with motility, also helps sperm survive their journey after men ejaculate, with the goal of finding the egg, fertilizing the egg, and impregnating women, which is why we're all here. So that's really the function of the prostate.
Okay, so it has a urological function, meaning urination, people watching, peeing, using the bathroom, going number one, if we make it real basic, and then also the sexual function of the prostate. So that was actually my next question for you is, okay, so it is an organ, it's something that only men have. So women, don't say you're eating tomatoes for your prostate, you don't have a prostate. Men and women have pelvises, but women, you have something different in your pelvis area, and men, you have something else.
And I have had that question sometimes when I speak to audiences. So I'm glad you covered women, no prostate.
Yeah, because people don't know. They didn't have anatomy class, most folks. So prostates are specific to men, and so I want to go over again the sexual function of the prostate, because a lot of times what happens is that, well, first of all, men are nervous about getting that prostate exam, and that's because of where it's located, right, which you just kind of repeat that. It's in the pelvis, and we have to do we have to go through the rectum to get to the prostate, correct?
Right, absolutely. So, if you men who've had a prostate exam, which really, if you're over 40, especially if you're a brother or a person of color, you should have had a prostate exam with your family physician or your internal medicine physician. The prostate is also sort of located in front of the rectum. So in order to examine the prostate, your doctor would have to do a rectal exam. They would have to go in several inches where they can locate the prostate, and it's sort of on the lower side of the rectum there. And with an experienced physician can probably feel about a third of the prostate on a prostate exam. So it's not the greatest test in the world, but it is a part of the screening test that we can use to find prostate cancer early.
Okay. And so listen, let's I want to emphasize what you just said. If you are a Black male or minority male, Black African-American Islander, you need a prostate exam by the time you're age 40, correct?
Yeah, so that kind of leads into screening for prostate cancer, which is, it is a very controversial topic, but just to kind of keep it simple, for me, for any people who would be considered high risk, which would be anybody of African descent, like you said, any brothers, for down in Dade County in there, you got a lot of Haitians, a lot of Afro-Latinos, a lot of people of Puerto Rican descent. Anyone who is of African descent would be considered high risk by most prostate cancer doctors. Or for any brothers out there of any race or any background who have a strong family history of prostate cancer, they need to definitely talk about screening with their doctor and consider getting that done. And, just to kind of clear things up, screening is a test that doctors use to pick up conditions earlier with the goal of improving your outcome of that condition. By catching it early, you're increasing your chances of cure. So if you get screened for prostate cancer, is diagnosed, you hopefully diagnose it early, and then your chances of curing that prostate cancer increase. Same as for women in mammograms and colonoscopies and other things that, obviously we talk about and hopefully our audience has spoken about with their physicians. But for any men over 40, you definitely want to have a conversation with your doctor about screening for prostate cancer. And that involves the digital rectal exam or prostate exam, and also a PSA, which is a blood test.
Okay. So guys, so we've already defined what the prostate, if you're coming in late, we talked about what is a prostate, the two main functions of the prostate. Then we kind of went into the prostate screening for cancer. So Dr. Moore talked about the digital rectal exam or rectal exam and why it's important, when you should have it, and if you're African American or of African descent, why you should have it maybe earlier than the majority. And then also the blood tests, the PSA, the prostate, is a specific antigen?
Yes, prostate specific antigen, PSA. Sorry for, of course you know that.
Listen, I've been out of residency for 13 years now? So, and out of medical school
it's like riding a bike. It's like riding a bike.
Right. But I applaud myself when I can remember some little things like that. No. So guys, so the rectal exam, the PSA, before we move on to the next question, let's say again, tell us again, why do men have a prostate?
Yeah.
The two major things again.
So the major function of the prostate is to produce and secrete prostatic fluid, which is a part of semen, along with other things, obviously. But the goal of prostatic fluid is to basically help the sperm. So they basically increase sperm motility, increase sperm survival. And again, the goal is when we have sex and when we ejaculate, the biological goal is for the sperm to impregnate the egg to create a baby. Again, that's why we're all here. So really the prostate, its main function is to help men get women pregnant, quite simply. It does serve some other functions. Like I said, it's at the base of the bladder. So it can sort of serve some function with urinary control as well. But the main function is sort of sexual reproductive.
And I wanted you to reiterate, because we'll come back to that, right? Because there are a lot of men who don't feel like a man anymore because he's had his prostate removed.
Absolutely.
And so, you just basically said if you're older and you've already had your children, then maybe your prostate is not the most important thing in your life when you're in your 70s or you're in your 60s, and you may have to have undergo surgery to remove your prostate. All right.
And look, because some of our brothers may sign off early. If you have your prostate removed, you are still a man. You can still have sex. All those things that you did before, you can still do it. So let's get that out there right out front, just in case somebody has to run out for dinner or something like that.
I love it. So guys, if you have to have your prostate removed, you are still a man.
Absolutely.
Yes, you don't have to come and see someone like myself, who's a mental health expert, to help you because you feel down because you may have to lose your prostate. You are still a man. You heard it from the expert here, Dr. Moore. Now, next question. Why do men develop prostate cancer?
So the answer is we really don't know. And I know a lot of times physicians and science, we hate to say we don't know, but we really don't know why some men develop prostate cancer and some do. It is very prevalent. It's the most common non-skin cancer in men in the United States. About 1 out of every 5 men of African descent or Black men will get prostate cancer in their life. 1 out of every 6 white men or Caucasian men of European descent will get prostate cancer in their life. So it's extremely common. It's one of the number 1 killers of men with cancer as well. So very prevalent, but we still don't know why it happens. The sort of accepted scientific thought is that it's testosterone driven. So testosterone, as we all know, is the hormone that actually men and women both make testosterone, just like men and women both make estrogen and the other hormones, but men have more testosterone than women. So we know that testosterone is sort of the main biochemical driver in the body for prostate cancer. But again, we still don't know why some men get it and some don't. Like most cancers, it's also a disease of the elderly. So the average age is probably around 65 or 66. But we do see men as young as men in their teens with prostate cancer. So basically any male of sexual maturity age could develop prostate cancer. And one thing that's concerning is we're starting to see more and more young men, more young brothers with prostate cancer, under age 40. That's increasing probably about 1% to 2% per year since the 80s. And what's very concerning about that is that because it's under 40, we don't screen those patients. So, but that's kind of a long answer to your initial question, but we really don't know what causes prostate cancer, but testosterone has something to do with it. There's probably some lifestyle factors as well.
So do you think that in these men who are developing prostate cancer at a younger age, do you think it's testosterone driven? Do we think?
Honestly, I don't really know. And that's not an area that I've researched extensively, but it's probably more environmental driven. As our society develops, there's more sort of things in the environment that may increases our chance for cancer. So it probably has something to do with that, but that's a very complex interplay. But most likely it has something to do with lifestyle and environment.
Okay. Dr. Moore, expound on that. When you say environment, what exactly do you mean by environment and lifestyle?
Right. So that involves anything. We're maturing faster, both men and women. So men are reaching sexual maturity at a younger age, as are women on average now. A lot of that has to do with our nutrition and our diet. Probably some of that has to do with, consumption of animal products, many of which contain things that either would promote sexual maturity or actually drive it as well. In a lot of the foods we eat, there's testosterone that's placed in the meat and estrogen and things of that nature to make the animals bigger and produce more meat or more milk. So some of it's probably associated with that. Who knows if there's other things in the environment in terms of, exposure to radiation. These are all other theories that are out there. But again, kind of getting back to the initial thesis, we really just don't know. Most of these are observational studies just saying that it's happening earlier, it's happening more common, and we're sort of, as a medical community, trying to figure all those things out.
So why 1 in Black men or in comparison to 1 in 6 white men?
Right. Another excellent question, and we really don't know. Some of it probably is genetically driven. But, an interesting thing is if you look at rates of prostate cancer in sub-Saharan Africa, where obviously most of our ancestors came from, and you compare that to rates of prostate cancer in, say, Jamaica, and then in the continental United States, there's differences there. So we don't know what causes those differences, but we know that those rates of cancer are less. And it also would be interesting to look at when you look at sort of in sub-Saharan Africa, people in rural environments that don't have a Western diet or Western lifestyle versus people in major cities like, Johannesburg or, Accra, Ghana, where they are adopting more of a Western lifestyle and Western diet. We're seeing that their prostate cancer incidences are going up. So as they act more like us, eat more like us, their prostate cancer rates are going up. So suggestive that there is something to do with diet, as a big driver, which is not really a surprise with, a lot of the disease conditions that we see.
Gotcha. All right. And the next question is, this is a good segue because it is, how can a man reduce their risk of developing prostate cancer? And you kind of just mentioned some of those things, but we'll, just blatantly state, what can one do? Right. If I'm a young man, I'm 18, 19, and I'm thinking about my lifestyle and I don't want to develop prostate cancer. And I'll say this, I think I remember in medical school or somewhere during training, one of my preceptors or attending saying, if a man lives long enough, every man will develop some form of prostate cancer.
Right. Yeah. So good question. Just to kind of touch on that last point that you made. It is a disease of the elderly. So the older you are as a man, the more testosterone exposure you've had. So more likely you're going to get prostate cancer. There's some studies where they looked at cadavers and autopsies. Basically, they did autopsies or medical examinations on people who've died, and they found rates of prostate cancer as high as 70, 80%. Wow. Which speaks to that, obviously, a lot of us will develop prostate cancer, but many of those patients, many of those men didn't have symptoms from their prostate cancer. So it was there, but it wasn't causing problems. So prostate cancer comes in many different flavors and varieties. Some are super bad and will kill you quickly. Others are not so bad. They're there. They've probably been there for years or decades, and they never cause you any problems. So, so your preceptor or your professor back at University of Maryland was 100% right. So, in terms of prevention, the prevention piece is, again, another complex interplay. We kind of touched on that a few minutes ago when we looked at incidents. But in general, there's not any one specific thing that you can do. You can't eat, green apples or grapes or, drink, red wine that will decrease your chances of dying from prostate cancer. But I always tell people that the number one killer is still cardiovascular diseases, stroke, kidney disease, heart attack, coronary artery disease. And that's all as an interplay, as you know, with diabetes as well, which is an epidemic in our country. So really the best thing you can do in terms of health for prostate cancer is to have a good cardiovascular-based diet, a cardiac healthy diet that a lot of us call it. And it comes in a lot of different flavors, the Mediterranean diet, the diabetes diet, et cetera, low sodium diet. So those things tend to be plant-centered, meaning, you eat a lot of plants. Doesn't necessarily mean you have to be vegetarian or avoid all meat, but they tend to be plant-centered, meaning the majority of the calories in that diet is based in plants. When they do consume protein, it tends to be healthier proteins, lean meats, fish, things of that nature, avoiding red meat and processed meats, which that also probably sort of speaks to obesity, which we know is a risk factor for prostate cancer as well. So really, you just want to maintain a good quality diet that goes along with cardiovascular health, but also be active. Anytime you turn on the TV, former First Lady Michelle Obama talked about, getting everybody moving. So really the same things that our grandparents taught us when we were young: eat your vegetables, exercise, go outside and play, overall be healthy. And that in and of itself will decrease your mortality in general, but also from prostate cancer.
Gotcha. Okay.
So really just super simple.
Gotcha.
Vegetables, avoid bad meat, and, exercise for 30 minutes a day.
So yeah, that seems to be the recommendation for a lot of things, right?
Absolutely.
So,
as you know, that also improves your mental health as well. So
yeah. So we need to have that as our basic foundation of how we live. It needs to be our lifestyle. Is prostate cancer genetically linked?
Yes. So anywhere from 5 to 10% of cases. So 5 or 10 out of every 100 cases of prostate cancer, there's some genetic linkage. And there's multiple genes that can cause prostate cancer, including the breast cancer gene that we're all familiar with from Angelina Jolie and a few other people. But there's probably half a dozen other ones that we know about. And there's probably 100 dozen others that we don't know about yet as a scientific community. But we see clusters of prostate cancer in families. I'm actually an example, to tell you the truth. Both my grandfathers, died of prostate cancer. And one of my mother's brothers also had prostate cancer. So, that's what we call a family cluster. And many of those were at a relatively young age, late 50s, early 60s. So
that was my next question. How old were they when they were diagnosed?
Absolutely. So that's what we would call a family cluster. Usually when you have 1 or 2 first-degree relatives, parents, grandparents, or siblings, that would qualify as a family cluster. But then obviously the more extended family members you have, and then anyone at a young age, under the age of 50, roughly. But a lot of that's still being worked out in terms of the scientific community, in terms of finding those genes, learning how to test for them, and then what the heck do we do about them when we do find them? So, gotcha. But certainly a fair amount that we know of is genetically linked. So it's important, super important that you know your family history. So many of us, come from blended families, or we don't know our father, or our mother died young, or, mom never talked about her history, or dad never went to the doctor. So it's important that we talk to each other and know about our family history. And that's a perfect example. But that lends itself to a lot of other things as well. So many conditions are genetically linked that if we don't know our history, we're sort of behind the eight ball when in terms of trying to fight and, manage any disease.
Sure thing. Yeah. My family on my dad's side, we had a Zoom meeting last month to discuss our family medical history. So everyone knows, what our family members have passed away from or succumbed to at an early age, and what not, that whole runs in my family.
Super idea. That's honestly, I never heard anybody doing that, but that's a super idea. We should all be doing that.
Yeah, because my younger cousins, they don't know. I think a lot of them, they don't know that they didn't have that information. But sidebar, is that what inspired you to become an oncologist? Your two grandfathers and an uncle?
Absolutely. So all four of my grandparents died from cancer. So both my grandfathers had prostate. My father's mother died of breast cancer, and my mother's mother died of complications from uterine cancer. So that was kind of like my introduction to medicine. Obviously, I was young when several of them died, but that's the first time I ever remember being inside of a hospital, a big hospital, and seeing people inside the hospital, seeing, all the stuff that we see on TV. So absolutely, yeah, that was definitely an inspiration for me.
So that was in your personal essay for your medical school application.
It probably was. I think it was, as a matter of fact.
I know it was.
It must have worked, right?
Yeah. Thanks for sharing that, though, because we get our inspiration from somewhere. So
absolutely.
Before I go on to the next question, what does prostate cancer look like? Or I'm sorry, more specifically, if someone has prostate cancer and they're not asymptomatic, right? What symptoms might they have? What could be an indication to a man that he might have prostate cancer?
So that's an excellent question. The vast majority of people who have prostate cancer do not have any symptoms at all, and which speaks to the huge importance of screening. Yes. So you don't have symptoms, and the same can be said for breast cancer. The vast majority of women who have breast cancer, they don't have any pain in their breasts or lumps or bumps or anything. They get a mammogram. So the overwhelming majority of men who have prostate cancer is picked up because they have a high PSA or they have a positive prostate exam. Their doctor does a prostate biopsy and bam, they find the prostate cancer. So I don't know the numbers off the top of my head, but I know it's the overwhelming majority. I would say probably 60, 70, 80% of patients do not have any symptoms. They're diagnosed via screening. So screening is hugely, hugely, hugely important. Unfortunately, if you present with symptoms, that means your disease is probably advanced. So some of the classical symptoms would be back pain, meaning that the cancer has spread to your bones, usually your spine. Another classic example would be hematuria or peeing blood. So if you see blood in your urine, and that's across the board. Actually, let me just touch on that for a second. If you ever see blood in your urine, period, you need to call your doctor. Simple as that. There's no condition where you should see blood in your urine ever. And sometimes it can be something very basic, like a urinary tract infection, but other times it could be something terrible like prostate cancer or kidney cancer. So that would be another common presentation would be blood in the urine. But other things that you could see more rarely would be headaches. Again, evidence that maybe is spread to your brain, shortness of breath or cough, evidence that is spread to your lungs. So usually people who are presenting with symptoms, oftentimes their disease, unfortunately, is advanced and much more difficult to treat at that point.
Gotcha. So so men, you may not have pain in your rectum. You may not have pain during rectal sex, or because I've heard my patients say so many different things like, oh, this isn't happening or that isn't happening. I don't need to go get screened. Because we ask patients about preventative care. Women, have you had your mammogram? Did you get your pap smear? And the same for men and the colonoscopy. And because some of what we do in mental health is still primary care. Guys, you may not have symptoms, so please don't go by that.
That's the number one thing that I always want patients to take away from any discussion medically is screening saves lives. So, most cancers, if caught early, including prostate cancer, is curable. But if you don't get screened, you're not going to catch it early. On the flip side, most cancers that are caught late are not curable. We're doing a better job now than we did 5 or 10 years ago, but still, you got a much tougher uphill climb if your disease is caught late and when it's already spread.
Wow. Could you say just a little bit? I don't want you to go into a lot of details because I know it can get complicated, but say a little bit about staging.
Yeah, so staging, quite simply is how far or how not far your cancer has spread when it was diagnosed. And I usually try to keep it simple with staging. So you have stage 1, which is early, stage 4, which is the highest stage, which is late. And then, of course, you have 2 and 3 in between there. So a stage 1 cancer where it started is where it is. So that's a small tumor. If a stage 1 lung cancer, you have a small tumor in your lung. A stage 1 prostate cancer, you have a small tumor that's inside your prostate. A stage 1 breast cancer, you have a small tumor in the breast. Most of the time, those stage 1 cancers are caught with screening. So you don't have any symptoms. We just do a test, we find it. Stage 2 is a larger tumor, but it's still in that same area. So a stage 2 prostate cancer is still inside the prostate, but it's a larger tumor inside.
If you can hear me. Okay. All
Can you
right.
hear me?
Say that last part again because you froze a little bit.
I'm sorry. So a stage 2 prostate cancer, you have a larger tumor, but it's still inside the prostate. Stage 3 means it's starting to spread. So either the tumor is big enough to where it's broken outside of the prostate, or it's spread to other areas around the prostate down in the pelvis, like your lymph nodes or other soft tissues that we see. Stage 4, again, which is the highest stage, means that it's spread to another organ. It started in your prostate, it's spread to your liver, it's spread to your lungs, it's spread to your bones, spread to your brain. So, and again, most stage 4 cancers they're very difficult to cure. They can be done, but it's a lot of work involved with curing a stage 4 cancer.
Gotcha. So one of my patients came and said, "Doc, my doctor told me to have my prostate removed."
Right.
And he started to cry. What do you say to a patient when that's the recommendation? Will it affect their life? I know we talked about it in the beginning of this session, like what the function of the prostate and how it can affect a man's life. Will it affect erections? That's the first thing. Is like, it's going to ruin my sex life. I won't be able to achieve an erection or get hard, or I won't be able to ejaculate. I won't have sexual desire or libido. So if someone has their prostate removed, can it affect those things? Let's take libido first, sexual desire. Does it affect that?
Right. So, well, as you know, sexual desire is a complex interplay between physical conditions, between, psychosocial, between lifestyle, et cetera. So, that's a complex interplay that is clearly well beyond the scope of any discussion that we would have tonight. But that being said, with treatments for prostate cancer, the way they look at it is they measure impotence or lack thereof. And basically all that's defined as is the ability to have intercourse. Mm-hmm. So they don't, necessarily look at sort of sexual drive, again, because that's a variable that can, depend on age. Obviously, a man who's 40 may have a different sex drive than a man who's 75. A man who has cardiovascular disease may have different sex drive than one who doesn't. A man who has depression or anxiety and is on, medication for that may have a different libido than a man who doesn't, et cetera. So as you know, that's a complex interplay. But speaking strictly from the ability to have intercourse, it does have an effect, treatment for prostate cancer. It's usually very minimal and much better than we did, say, 10 or 20 years ago, because our treatments are better, but also the side effects from those treatments are better. So, for instance, if you have a local prostate cancer, and there's a lot of different treatments for local prostate cancer, which I'm sure we'll talk about in a little bit. But let's say you have to have your prostate removed. Like your patient said, Doc, this doctor's telling me he needs to remove my prostate to cure my prostate cancer. With new treatments for prostate cancer, which is primarily going to be a robotic assisted surgery. So, essentially the robot is assisting the surgeon to be more precise with their surgery, which basically means there's going to be less side effects and less long-term issues. If we look at large data sets, large groups of patients, their ability to continue to have intercourse is somewhere in the 90% range. So, 80 to 90% or 80 to 90 out of 100 of these men are going to be able to achieve intercourse. Obviously not right away, but they'll usually look at it at 6 to 12 months. So absolutely. Absolutely. Yeah. Now, the other side effect that we look at is incontinence. A lot of men worried about, peeing on themselves or having to wear Depends or dribbling or things of that nature, which, as you know, varies with age as well and the size of your prostate and other things. But with those, with the newer studies that we're doing, the newer treatments, again, the robotic assisted prostatectomy, continence rates are, 98%, meaning 98% of men don't have to wear a pad. They're not peeing on themselves. They're not running around smelling like urine on a regular basis. So, excellent outcomes with both intercourse, the ability to continue to have sex, but also the ability to continue to control your urine stream.
Okay, you're right. That is important. If someone is smelling urine all the time, that's a Debbie Downer for them.
Absolutely.
Yeah.
But we've done much better. In the past, those rates were as high as 50%. So, probably 20, 30 years ago, before the robotic surgery became prevalent, incontinence rates and impotence rates were as high as 50%, which is, you had a coin flip chance of not being able to have intercourse, but then not being able to control your urine stream as well, which, as you know, can cause a whole lot of problems. Right.
Okay. So I guess we're sort of near the end. We talked a lot about prostate cancer. You included a lot of extra tidbits. Thank you for that. So people should be more informed. We're not going to go into a whole lot of detail about treatment. I'm sure people get more time with their oncologist than they do with their primary care doctor, so that you can explain the options to them so they can be an informed consumer, really make a decision as to whether or not they want to undergo whatever treatment you're recommending. But and it seems like the advancements in treatment of cancer have come a long way. So from talking to my patients, when they tell me what they're taking or what types of treatments they're undergoing, can you tell us what the options are now? I know it depends on staging and all these different factors, but sort of a basic or broad overview.
Right. So it is very complex. It depends on a lot of things, like you mentioned. It depends on stage, which we talked about a few minutes ago. It depends on the condition of the patient. Obviously a younger man, 45 or even 60, healthy, is going to have a lot more options than a man who's 90 or a man who's 65 and not healthy. But it also depends on whether your goal of treatment is curing that prostate cancer, which is going to be early prostate cancer, stage 1 or 2, or is your goal to sort of control the disease and prevent problems from happening, what's the case with more advanced disease, stage 3, and definitely with stage 4. All that being said, the most important part is that you need to get a multidisciplinary evaluation, which in simple terms means you need to see doctors from different specialties. You touched on it in the beginning when we first jumped on the call today. There's doctors in all different kind of specialties, but when you have prostate cancer, you definitely need to see a urologist, which is a prostate surgeon, bladder surgeon, kidney surgeon. You most likely need to see a radiation oncologist, which is a doctor who treats cancer with radiation. You may need to see a medical oncologist like myself, which is, again, someone who treats cancer with medical therapies, pills or infusions. But you may even need to see some other types of doctors, interventional radiologist. You might need to see a lot of patients. We do send a psychiatrist beforehand to sort of get, to sort of help them tease through managing some of the side effects and how they want to decide which treatment to do. You also need to see a radiologist who's an expert at looking at your screenings, exams, and your pictures and your CAT scans and deciding what the best treatment may be. Nowadays, you also need to have a pathologist evaluating your biopsy, which is also going to increase your treatment options. So, the key there is you want to get as much information as possible and make sure you're getting to see the right doctors. And then what we're doing now, we have these things called tumor boards where we all meet as a team and we decide what is the best treatment for that individual patient. And like I said, it's usually going to be some combination of surgery, radiation, and medical treatments.
All right. So, and
I know that's a mouthful.
No, it's cool though, because people have to know what to expect, or if it's someone who
Absolutely.
watches this now or later, and maybe they know someone who was diagnosed with prostate cancer and they're wondering what has to be coordinated. What do they have to do? Just gives them
Absolutely
a lot to think about. Because, I was thinking chemo, radiation, and so.
Yeah, and those are all often parts of it. But, again, it just depends on where you are, what stage. But you definitely need to be having all those conversations. A lot of times what will happen is you'll go see one type of doctor. They'll say, this is what you need to do. And if you haven't got input from another type of doctor that also treats that, then you might not be getting the best treatment for you.
Wow. It's just one of those things where if you don't have, if you're a layperson,
Right.
this could be overwhelming. This could be overwhelming, trying
Absolutely.
to coordinate all these different types of care and interventions. And if you don't have someone advocating for you to assist with that, man.
Absolutely. And you're in South Florida, obviously a major metropolitan area. I'm in the DC area, major metropolitan area. But imagine we got patients living in, rural Virginia or, rural Alabama or rural Texas or in Alaska, where they may not be able to get to a medical center where they're seeing all these different types of doctors. But then, there's even studies out there to say that, people of color, people of African descent, that we're treated less aggressively than our white counterparts, or, people who may be underinsured may be treated less aggressively. So, it's important that that stuff like we're doing right now, where we're educating people to get out there and, at least be armed with the right questions to ask, this doctor. The other thing that's out there, obviously, there's a lot of resources on the internet. Again, people always make jokes about Dr. Google, and I always tell my patients, there's nothing wrong with going on the internet, but it's what is your source? What are their credentials? Have you vetted them? Which, you talked about at the beginning of our discussion. When somebody who has excellent training and they've been vetted by their peers, they've been checked by their peers, you can trust what they're going to say. Whereas if somebody doesn't have the best training and, they haven't collaborated with peers in their group and been reviewed, then, you might want to question what they're saying.
Yeah. Yep. So you said a lot of good stuff. These, your last, everything has been good, but, I really think I can wrap it up there. I asked you so many questions. I don't think it's still, no one has called my 951 my brain tonight, surprisingly. So what they'll do is ask me later in my DM, what's the number again? And I'll tell them, well, he's not on now. So, that's just how it goes sometimes. But I think I asked all the questions that folks did DM earlier and kind of emailed. I asked people to send me questions. And so that's how I came up with the questions that I did ask you. I appreciate your time. I wanted to end on just what you were saying about coordinating care, how important it is to vet your doctor. Because it's just like anything. I tell people, if you're buying a car, you want to do your research to make an informed decision. So your body and medicine and your health is no different.
Absolutely. Agree 100%. You want to check credentials. You want to, and the other thing I'll add is there's nothing wrong with getting a second opinion. Sometimes, people are afraid to get a second opinion. Even some of my parents will be they'll think they're offending me if they're getting a second opinion. I always tell people, there's nothing wrong with getting a second opinion. If you're not 100% comfortable with what a physician is telling you, then, always go ahead and get a second opinion, and that gives you more information. It helps you make an informed decision.
Yeah. Yep. So any last words or anything you'd like to leave with the viewers?
No, well, so I've said it before. I want to say it again, though. Screening, talk to your doctor about screening for prostate cancer. Screening for all cancers saves lives. Any patient, man, woman, who's on this call, every year when you see your doctor, you want to ask him, am I up to date on my cancer screening? Because that's the best way that you're going to be able to catch your cancer early and cure it. The other thing is, if you have patients or interested callers or fans or whoever who reaches out to you and have questions, you know how to get in contact with me. I'll be more than happy to answer those questions and, follow up with them. So. Yes.
And I like that. Am I up to date on my cancer screenings?
Yes. That's at your annual physical, your annual checkup. That should always be a part of the conversation, especially for, any adult, anybody over 30, essentially, anybody over, mid-20s, but certainly, people, over the age of 40, absolutely needs to be covered every single year.
Okay. And that is the word, y'all. This was the Cancer Talk. So we're going to leave it with that for Therapy Thursday. We're not talking a mental health issue, but this is important. June is Men's Health Awareness Month. So I wanted to come on with Dr. Jeffrey Moore, hematologist, oncologist. And if you weren't able to watch live, hopefully you can watch and listen later listen on my podcast, The Brain Love Podcast, on most podcast outlets or mediums. So Google Podcasts, Apple Podcasts, Spotify, Anchor, of course. And of course, you can watch here on YouTube. Thank you, Dr. Moore.
Thank you so much, Dr. Delvena.
So
I'll see you soon.
Before you hit end, you got to say brain love.
Brain love. I wish I could say it in Spanish too.
Yo hablo español, ¿y tú?
Un poquito.
All righty. I appreciate you. Thank you.
You're welcome. See you later.
Okay. Good night.
Bye-bye.